have a collecting tubule, cortical collecting tubule, and the collecting tubule is basically divided into two regions based on its anatomy. There is a part of collecting tubule that falls in the cortical region and is called as cortical collecting tubule, and then there's a part that falls in the medullary region or in the medulla of the kidney and is known as medullary collecting tubule. So now we'll discuss the collecting tubule segment of the kidney. In the collecting tubule, as we can see that there are um, two major components or that are playing role in the reabsorption. Number one is the aldosterone. Aldosterone is a hormone that is secreted by the body. It is a hormone that basically causes the now what it does that it increases the reabsorption of sodium inside the cell, and it increases the excretion of the potassium into the outside of the cell, into the lumen of the urine. So this aldosterone, it acts on the ENaC, which is the channel. It is an exchanger of sodium, and this channel, with the help of this channel, what it does that causes an increase in the influx of sodium and an efflux of potassium. So as a result, what do we have? We have an increased concentration of the sodium in the body, and we have an increased excretion of the potassium outside the body. So this is the net result of aldosterone action on the body. However, we can also see that in the intercalated cells, the bicarbonate is being transferred, is reabsorbed, it is being transferred from inside the cell into the interstitium of the blood, and the proton is, or the hydrogen ion, is going outside. So this is what happening in the cortical collecting tubule, and the drugs which we are going to discuss now are the drugs that act in the cortical collecting tubule. So first we have potassium sparing diuretics. So all these diuretics, they are known as potassium sparing diuretics because as we have learned that with the use of rest of all diuretics, there is a decrease in the concentration of potassium in the blood. So these are the diuretics that do not affect the concentration of potassium, and on contrary, they increase the concentration of potassium in the body, they spare the potassium. So that is why they are collectively known as potassium sparing diuretics. So now we have two groups of drugs that fall under this category. Number one is spironolactone and eplerenone. The other group is these two drugs, they act on the aldosterone receptors. The other two drugs that fall under this category are known as amiloride and triamterene. So these drugs, they act on the ENaC channels, and they directly act on the ENaC channels, and they are direct inhibitors of sodium influx. So these drugs, they blocks the activity of the aldosterone by acting as an aldosterone receptor antagonist. And these two drugs, amiloride and triamterene, they directly act as sodium influx inhibitors. So this is how both of these drugs, and they both fall under the category of potassium sparing diuretics, and both of these groups, they act in the collecting tubules of the kidney. So we can predict the effect of these drugs by their action. As we have already discussed that now spironolactone and eplerenone, they will bind to the mineralocorticoid receptor and they will antagonize the effect of aldosterone. As a result, there will be decreased sodium in the body and there will be increased potassium in the body, right? So the other group, which includes the amiloride and triampirine, so both these drugs, amiloride and triampirine, what they will do, they will act on the ENaC channels and directly inhibit the sodium influx. So this is how they produce their effect in the body. As far as the pharmacokinetics is chemistry or pharmacokinetics is concerned, the spironolactone and eplerenone, both of these are steroids. They have steroid nucleus. We have two drugs, spironolactone and eplerenone. And both these drugs, they have a steroid nucleus. Spironolactone have a slower onset of action and spironolactone have a more pronounced side effect profile as compared to eplerenone. Whereas the eplerenone, it is more selective for the mineralocorticoid receptor and it has low efficacy for all the other effects of all the other hormonal effects that are produced by the spironolactone. So it is preferred over spironolactone. So as far as the clinical uses are concerned, they are used in the treatment of hyperaldosteronism. So all the conditions in which there is an increased concentration of aldosterone in the body, spironolactone is used in that, which include Conn syndrome, ectopic ACTH secretion in heart failure, in cirrhosis. As in cirrhosis, there is an increased concentration of aldosterone in the body. In nephrotic syndrome, so spironolactone and eplerenone, both of these drugs are used in all these conditions. So eplerenone, in the low doses, it may also interfere with some of the fibrotic and inflammatory effects of aldosterone, and it slows down the progression of the fibrotic and all the inflammatory effects of the aldosterone. The toxicity is of these drugs is number one is hyperkalemia, as they are potassium sparing diuretics, so they will increase the concentration of potassium in the body. They can cause gynecomastia and impotence. Gynecomastia in males and also impotence. They can also cause benign prostate hyperplasia, as they because they spironolactone is more associated with all these kind of side effects because it has a steroid nucleus and it interferes with the activity of the other hormones which can lead to these side effects including gynecomastia and impotence and all these. It can also cause acute renal failure in the patients who are prone to renal failure. They should never be given in patients who have chronic renal insufficiency or who have liver disease because they're metabolized in the liver. They should not be co-administered with RAS inhibitors because they may increase the concentration of potassium. They should not given with strong CYP3A4 inhibitors because as a result we can see that there is because the metabolism is basically prohibited by the CYP inhibitors. So the concentration of the drug will be more in the body. So this was all about the potassium sparing diuretics. Now we'll move on towards the medullary collecting duct. This is the second, the last part of the kidney, and in the medullary collecting duct, we can see that here we have aqua porins, and mostly the water is being transported inside of the um, from the lumen into the collecting tubule, and the transportation of water is mediated by the aquaporins. Now these aquaporins, they are directly related to V2 receptors, which we can see here and here. These are the present in the epithelium of the medullary collecting duct cells, and these V2 receptors, they are known as vasopressin receptors. Vasopressin is also known as ADH, which the full form of, or the full abbreviation of ADH is antidiuretic hormone, which means that it will prevent or it will act against the diuresis. So this is known as antidiuretic hormone because it retains water inside the body. So what will happen if we block these receptors? There will be loss of the water from the body. So this is a very pretty straightforward mechanism, that we have receptors which are known as V2 receptors, vasopressin receptors, and they are called as V2 receptors because we also have other kinds of vasopressin receptors in the body. Some V2 are in the kidneys, and V1 and V3 are distributed throughout the body. So these V2 receptors, they will they will affect the aquaporins, and they will cause the influx of water. So this is how they retain water in the body. And when we give or when we administer any drug which antagonizes the effect of these aquaporins or these vasoreceptors, the effect is pretty straightforward, that the water will go out. It will be excreted from the body. So this is how the effect of diuresis is mediated. There are certain drugs that are used as antidiuretic hormone antagonist, as ADH antagonist. So these drugs are used in the treatment of congestive heart failure, and also there is a syndrome which is known as SIADA, which is a syndrome of inappropriate ADH secretion. So ADH antagonists are used in this condition, and they are used in congestive heart failure. So the drugs that are called as ADH antagonists, the most important of these drugs are Veptans. These Veptans have the class have two drugs, Conivaptan and Tolvaptan. Now, both these drugs, they're used as an anti-ADH, or they're used as an ADH antagonist. And the Conivaptan, it acts on V1 and V2. Tolvaptan, it is selective for only V2 receptors. So it is more selected towards the receptors in the kidney. It has a half-life of 12 to 24 hours. And the Conivaptan, it has a half-life of 5 to 10 hours. So we can judge that Tolvaptan is a better drug because it is more selective for the V2 receptors, which are the desired receptors in our case, and it also has a very long duration of action. So we can give the drug in once daily dosing. So we also have another drug which is used as ADH antagonist. It is known as demeclocycline. The names are a bit difficult to remember, but if we go through them like 2 or 3 times, it will be easier for us to remember. So the tetracycline, it has a duration of action which lasts for around 5 to 10 hours. There is also a drug called as lithium, which is an antipsychotic drug. It also has ADH antagonist properties. So what is the mechanism of all these drugs? Is they are going to antagonize ADH. So we are antagonizing the effects of ADH. And the uses, as I've already discussed, are used in SIADA and congestive heart failure. SIADA is syndrome of inappropriate, which means that the inappropriate ADH, which means that there is inappropriate secretion of ADH, and we have to counteract with the drugs. And the second condition is CHF, which is congestive heart failure. These drugs, they can cause renal failure because they drastically reduces the GFR. So this was all about the diuretics.